Hello, children of a lesser joint. Welcome to the next segment of today's video, which is a continuation of the giant cell arteritis or temporal arteritis that I discussed about my wife last time. We're going to see that I'm incorporating PowerPoint now into some of the presentations. I also have some good news. It's not totally good news, but it was on that young man. They finally made a diagnosis, and he didn't have a tumor. What he's got is sarcoidosis, and that can mimic a malignancy, especially when it spreads to structures in the central nervous system. This gives me an absolutely great opportunity to be able to teach you about some of the diseases here. Now, what I have on top is a classification of granulomatous disorders. Giant cell arteritis belongs to a larger category, and there are some really noteworthy diseases in here. A lot of them you've come across in the group because I know that you've mentioned them. I'm going to tell you about some of the ones that you know and some of the ones that you don't know in passing through over here. Number one is you have complications from Candida albicans. Number two is you see in the bottom left-hand corner over here, B. burgdorferi, that's Lyme disease. And then you have another big species, which I find all the time, particularly Mycoplasma pneumonia, which if I had one organism that I was going to bet on would be present in most of my patients with joint disease, I would bet on that one without hesitation. But as you come across the top category over here, it's small, but you'll notice it says vasculitis. And in that group are some really bad diseases. Number one is, because of the age of this article written in 2000, the names of some of the diseases had not been changed yet. So on top we have Wegener's granulomatosis, which is now called GPA, or granulomatosis with polyangiitis, as the new nomenclature would go. And that is a really destructive disorder, particularly of blood vessels. Its cousin is called Sjögren-Strauss, and that also has been changed. It's now called EGPA. Now, I have two patients with Sjögren-Strauss disease, and that also belongs to another category with Wegener's, which is part of the vasculitis category, as is another one which falls in here, which is polyarteritis nodosa. And of course, the giant cell arteritis is next to last with lupus. Now, below that are some of the immune diseases: sarcoidosis, Crohn's disease, primary biliary cirrhosis, which has a high overlap with celiac disease, and sarcoidosis shares an overlap with celiac disease. So we know that there are a lot in this category. The ones that you can't see, because my picture of the current video is overlapping in the bottom right-hand corner, is cat scratch disease. Now that comes from Bartonella, and I know there's at least one or two people in the group that have mentioned Bartonella. But on the bottom left here is also Yersinia, and that's part of a group which belongs to food poisoning in creating reactive arthritis. And in lectures to come, I'm going to go over a lot of these. There are also other organisms which could cause this. Tuberculosis is known to cause granulomatous diseases, and you see that in the mycobacteria group over here. But above that, we have spirochetes. Now, Lyme disease, B. burgdorferi, belongs to the spirochete group. There's also a dental pathogen, Treponema denticola, which could kind of forage into this group. Syphilis, Treponema pallidum, falls into this category. So there are a lot of organisms that are associated with this. On top over here, Epstein-Barr virus in the lymphoid granulomatosis. And I'm going to show you a case at some point in the future where you see the overlap of multiple diseases that actually can be incorporated into this whole thing. And then we have chemical toxins that belong to this group. Usually this is reserved for people who work within the industry, but I wouldn't necessarily rule out that people could have reactions to some of the things that are relatively common in having dental work done in some cases using talcum powder. We're now using zirconium in dentistry. Beryllium has been incorporated into some of the metals used underneath crowns. So all these things are things that I consider. Within the category, most important, a lot of people have common variable immune deficiency, and that has a substantial overlap with sarcoidosis as well. Totally 64 types of diseases within this group. And now what I'm going to do is I'm going to concentrate on some of the issues that I did not go over before and I wanted to amplify and make a bit clearer. So when I was talking about my wife, there was a sense of urgency for us to get moving really quickly once I suspected that in fact she had a temporal arteritis or giant cell arteritis as it's commonly called. Number one is I wanted her at the highest level of care as quick as possible, and if you recall, I went ahead and I made 3 appointments in advance. That same day we went to our primary care physician. She got some blood tests. I had an appointment waiting at that point for the next day, so we would have the blood studies in hand to go see our neurologist Anthony. And Anthony took a look at the blood studies, and he didn't think so fast that it was giant cell arteritis because her sedimentation rate was only 65 millimeters, and you're going to see that's coming up. But the urgent issue here is that within this category, blindness occurs in 15 to 20% of the patients. So you want to move fast, and you don't want to withhold the steroids, even though I probably knew that was going to happen. She had an MRI right on the premises. We got all the bad stuff off of there very quickly, and then I had an appointment, of course, waiting for her with the rheumatologist. The gold standard in terms of confirming that you have a giant cell is a biopsy, and the biopsy is generally done within a week after the start of the steroids, assuming that you're going to be placed on this. According to the American College of Rheumatology, 25% of giant cell arteritis are missed for a couple of reasons. Number one is they don't get the biopsy. Number two is the symptoms are a little bit off color, or even third is that you might not have the elevated sed rate and C-reactive protein, which can occur often. Secondarily, you might not have as much giant cell arteritis as you could have polymyalgia rheumatica. 50% of giant cell arteritis patients have polymyalgia rheumatica, which is the cousin over here. So again, I want the patient at the highest level of care very, very quickly. Number two is what you want to make sure that you do in these patients is you get the blood labs as quickly as possible. Now, interestingly, approximately 16% are going to have a normal sed rate within this group. Just not the sed rate and the CRP. You should get a complete blood chemistry also. So for those of you who are doctors in the group, you want to make sure that you do that, because thrombocythemia or thrombocytosis, which is an elevated platelet count, is going to go a long way, which can be associated with anemia, and anemia is one of the causes for an elevated sedimentation rate. So you want to make sure that you get that going. Additionally, a sedimentation rate is a very simple test. Let me just show you a little bit about what it is. They're going to draw some blood. It's going to go in a test tube, and then they're going to put it on a rack. And then after an hour, they're going to measure the difference between where the blood falls to, down below over here, and the plasma on top, which is a yellow clear kind of fluid, and they're going to measure that distance. The criteria, which is classic for temporal arteritis, is 70 millimeters per hour. So they're going to measure from here to here, and that's going to be 70 millimeters within an hour. If they're below that, depends upon the symptoms in the practitioner. So if you fall within that group that doesn't have that, you're going to be in trouble with getting the steroids. The classic symptoms of giant cell arteritis include the headache. That is the most prominent characteristic where they identify that, in fact, you have this disease. Most commonly, it's at the temples right over here, but it can actually occur anywhere in the head and neck, and that's one of the points that I'm going to bring about in just a few minutes. But the most specific symptom is jaw claudication. In other words, there is pain when you chew in the jaw. The symptom is not constant, and patients will develop a jaw ache when they eat, and because of that, they will decrease their food intake, and then they're going to be fatigued and weak. So these are part of the constitutional symptoms that we see in this disease. And of course, one of my favorite symptoms is the scalp tenderness that goes on over here. However, there are some really interesting symptoms that occur independent of these. And if you're off color and you're atypical, you're not going to have these readily identified. Now, let me bring some of these up because I think it's important for the patients in the group, and some of you are really going to see yourselves show up over here. Now, it doesn't necessarily mean that you have the disease. However, I think it's important to kind of focus on this, and I'm just going to go up here and I'm going to move this out of my way a little bit so that I can see my slides, which you're not going to see on the presentation as clearly as I can right over here. But I think one of the interesting things on this is vertigo is a first presentation of temporal arteritis, or almost a prodrome, because several years before my wife actually got this, she had vertigo, and to a certain degree she still has it. Notice how the earache and ringing in the ears, the tinnitus, show up. There sometimes, as a first presenting symptom, is the sore throat with a loss of normal sense of taste and a sour metallic taste in your mouth. And there's also some hearing loss that can go along with this, as well as abnormal smell, where all of a sudden you can smell everything in the world and it smells horrible, or you've lost your sense of smell. There's also pain right behind the ear. Another common symptom that I've seen in this is the patient who complains of their lips, gums, their teeth, and that's another symptom. Pain in the teeth can be a first presenting symptom here, but the swelling of the lips and the gingiva will also come along with the feeling of the tongue down over here. Actually, the tongue is over here, where the tongue has this feeling where it feels swollen, and sometimes there's numbness. A lot of people will complain about the burning and the shooting pain. So the tongue will also feel that swollen kind of sensation, or sometimes it has a tingling. But there are a lot of symptoms in here that overlap into the neuralgia kind of grouping, and then of course it can affect the abdominal region, because the arteritis is just not limited to the head and neck area. Concordant with this, and what comes along beyond this as I go down, is another issue. There's another type of autoitis, which is called occult autoitis. Occult means hidden. So it doesn't have the classic symptoms, and this occurs predominantly in the eyes. And this group has a much lower value to their SED rate and CRP, so they're not up there over 70, and yet a normal SED rate and CRP does not exclude the diagnosis in the presence of symptoms. And within this diagnosis, which occurs 20% of the time, what if I think a little bit outside the box? What if I say, if this can occur only in the eye, why not someplace else? So if I'm excluded from the normal classic criteria that might give me a diagnosis of giant cell, then the problem, of course, becomes convincing somebody who's going to put them on the steroids that, in fact, they do have that. And then you can go to a biopsy in any one of a number of areas. That's a possibility. 3T imaging, which is an MRI with a 3 Tesla machine, can be done MRA format and pick up some stuff in the blood vessels. Color duplex sonography is now being used here, even in lieu of a biopsy with outstanding results in Europe. So we need to get on the stick over here and be able to identify more patients with this particular disease. The visual symptoms are apparently among the most disturbing because of the blindness that can occur, and generally speaking, the vision loss is discovered mostly upon awakening. In addition to the vision loss which can occur here, we can also get double vision as a first presenting type of symptom, or an onset of temporary visual loss as a prodrome as well. The other part of this is neurological aspects, because it can affect cranial nerves. And so the nerves that go to the eye are affected often by this. And beyond that, we get to the next slide over here, an ophthalmology appointment to be able to identify whether or not you have abnormalities in the area of the retina, which is a disc that is right in front of where the optic nerve comes in and all the blood vessels, and you can see the little hemorrhages or the swelling of the disc in this particular picture, which is called papilledema. So it's important to use your resources in obtaining a diagnosis. When it comes right down to it, when I look at disease, I look for bugs. This is an article that was written by Gilden, and it talks about the prevalence of varicella zoster virus, which we all know is part of shingles, occurring in biopsies on his patient group in 74% of the temporal artery biopsies. However, in another article, they found additional organisms and didn't find any of the viruses like the varicella virus or the parvovirus B19. These were P. acne, E. coli, which we know comes from the gut, and Moraxella catarrhalis, which was mostly abundant in one of the controls that this study was done on, and that's found commonly in the sinus. So you can see, as I had gone over in some of my other posts and stuff, when we dealt with what causes susceptibility, neighboring territories do have an effect, especially those that are richly supplied by the blood vessels. The other part of this is, let's go back to the HLA, which was part of Marcello's Mattos's theme in some of the ways that he tests, and we see that the association with giant cell autoitis, which would give us a genetic predisposition, we talk about the HLA-DR4. Well, that overlaps significantly with rheumatoid arthritis. So here we have in the HLA-DR group some genetic factors which are tip-offs to the likelihood that you might get that disease. And I'm going to stop the segment at this particular point in time. I think the most important thing in the realization for the patient and the doc on the group site is that, number one, is there may be alternative presentations that we're not aware of. You can get pain in the maxilla, pain in the palate, pain in the mandible, pain around teeth, pain in the tongue, pain in the facial artery, which is reported in the literature. And you go and you take your regular x-rays and you're not going to see tooth disease. And then from there, what do? Where do you go? And so here I'm forearming you with a library of information that you can keep in the back of your head and you can use at a time when things are not so clear in your head. You say, oh, maybe this is something I should take a closer look at. The next time I'm going to be talking a bit about sarcoidosis. I may have to extend this to actually 3 segments where I'm going to compare the 2 diseases and the symptoms, and I'm going to talk about the overlap of diseases along the way to help you discover where some of you may have diseases that have been undiagnosed. Have a great day. Thanks for listening. Always a pleasure.